Yes, it is that time of the day in the afternoon again. Welcome to another episode where we have interesting guests teaching us about how to do things right and how to do things better. I'm going to start with something that you may or may not know. Did you know that evolutionarily, when we are in the caveman days, those who went out of the caves and hunted, and then they came back, those people would lead a discussion in a bonfire at night. The reason people gathered around to listen to these stories is because these are the folks who went out, hunted, gathered, and then survived. They're the ones who came back. They have the experience of having seen what is out there. And that is why people listen at the end of the day to these folks who went out and gathered. They are survivors. They have experience. That is why stories are so powerful. That's why we love listening to stories. And that's why when someone says, "Hey, I've got a story to tell you," you listen, because it helps you survive. In today's episode, I can't be more excited to hear from Marianne Desciose, Billing Director of PRS Network, also known as the painters, the gurus when it comes to urology, coding, and billing. She is going to share with us some of the billing and coding nightmare stories that she's heard as she travels across the country with the PRS team. I can't wait to hear what she has to share with us, because I know there's going to be some gems, and I know from which these stories are going to help all of us avoid costly mistakes. So welcome back, Marianne, and thank you again for showing up and sharing your wisdom. I so appreciate it.
Thank you for having me back. It's really nice to be here.
All right. I know you just came back from Texas from a consulting gig.
Yes.
Do you have any stories from that engagement, or maybe you want to talk about something else?
Recent engagement, yes. Stories that we have interacted with the providers there on a practice that they had recently been talking with and consulting with as well, regarding, just some plans of new physicians and onboarding some new providers in their location. And they shared with us a story of a group that they had recently gone and spoke with, and they had been posting all of their payments into insurance buckets rather than individually to claims. So for example, a payment from Blue Cross Blue Shield comes in, $2,000. They did not individually post for the past 3+ years to the patient's accounts for which that check applied to. They posted it into an account labeled Blue Cross Blue Shield or United Healthcare or so on and so forth. And so now they're trying to unravel, because their accounts, their individual accounts, they did not understand that the person who was posting this stuff was doing it in that sense. So patient bills have not been going out for 3 years. Collections were down. The person finally was relieved of her duties, and then somebody comes in and starts having to unravel this 3-year cluster in a system.
I just can't. I can't even.
Yes.
Are you kidding me?
No, not at all. And they're now trying to figure out how if you can imagine.
No, I can't. I can't. That's the problem. I can't.
I know. And we were sitting there and we're like, so what are they going to do? Well, basically they don't know what has or has not been paid. They don't have any way of knowing what's been denied. They've not been working follow-up. So therefore they are not only in a loss of money to unravel this, but they're at the loss of money because these claims that were denied, partially paid, are now most likely at a loss altogether in a clinic that thought, oh, well, I just am making the same amount of money that I've always made, so everything must be good. providers aren't asking questions, administration's not asking questions, a smaller practice. And here now they're looking to, try to go into another practice. And here we go.
So much to even unpack just in that short story. Number one, timely filing is
Oh, yeah.
gone. You 3 years later, forget it. You already missed timely filing. If you have to go back and resubmit the claim to the insurance company, you're screwed there. And
Correct.
number two, if this practice is the target of a private equity acquisition, one of the first things that the private equity group is going to do is to look at your books and look at how well
Correct.
the practice is run. And the valuation of that practice for acquisition depends on the savviness and completeness of how the practice is run.
Correct. And we see time and time again the misunderstanding of timely filing in mostly from providers, staff as well. People who are working the claims seem to understand it more, but in providers, we've been, approached saying, as long as I made an effort at some point, I can still get these paid. If I go to the payer and tell them I had an issue with a person who was wrongly, filing my claims, not filing my claims, that's not correct. There is very strict guidelines for timely filing. It is not a year for every payer. It is different payer to payer. And there's also timely filing also implies to your follow-up. So if you get a denial and you do not follow up within 45 days, for example, with some of the Aetna and United Healthcare, you are still out of timely filing from following up with that, and they'll still deny your claim.
Yeah, so it's not just, and also it's payer dependent, like you intimated.
Correct.
It depends on the contract with the payer. It depends on the individual payer's rules. Medicare is pretty easy to predict because the rules
Correct.
are national.
Yeah.
You got your max, but overall the rules are fairly uniform, relatively speaking. But individual payers may vary.
Correct. And they don't read their contracts to know that there's not only stipulations in the actual timely filing is the time you have to file a claim. The follow-up on the claim and your appeal rights change. So those deadlines often change with payer to payer, depending on A, your contract, and B, just their stipulations within that payer.
So I have to ask, where did they find this person who was supposedly posting remittances?
So from my understanding is that this person had worked at the office for some time and moved up into a position that was needed. They trained her. And, one of the things that is a common mistake that I feel is a mistake is that billing is not easy. Sending your claims out, putting the claim in the system, yes, that part is easy. But the making sure that it's accurate, making sure that you have a clean claim, making sure that you're following all the guidelines, it's very difficult. It changes sometimes daily. And there's a very big misunderstanding that this can just be done by anybody. So I think this person just moved up, thought she knew what she was doing. She's posting a check, almost like if you were posting it at a construction company. I got paid by a vendor. Here I'm posting it in QuickBooks. And that's how she decided to continue to post. And nobody asked any questions because they were getting money, but they could have been getting a lot more money, said business.
Yeah. Well, I've said this before. Just because you're getting paid doesn't mean that you're getting paid correctly.
Correct. And on that note, yeah.
Go ahead.
And on that note, just exactly that, just because you're getting paid doesn't mean that what you're doing to get paid is also correct. You can add modifiers to anything. You can add 59 modifiers. You can add 25 modifiers. They get paid. Doesn't mean they should be paid. And it doesn't mean that somebody's not going to come back and take that back at some point.
Okay. Exactly. The take back, the clawback, the chargeback, whatever it's called, that is always a risk when you just submit the claim willy-nilly, not following the rules, and they can always come back and get you. Or sometimes some people may abuse this power, and when the audits come, either from Medicare or private payers, the clawback is going to be painful.
Correct. And when we're seeing when we're working these accounts, when we're going out and consulting on these accounts, when we're hearing these stories just from hearsay through how things had worked before and how office had straightened stuff out from where it was, but they're still on a path of correction. We're sitting here and we're going, this is why we see insurance companies being able to do what they're doing now, is because there are, people in this Facebook group are trying to do things right. People are coming to the PRS seminars, are doing things, trying to do things better, trying to do them right. There are a large amount of people out there who either don't know or are not doing things right. And this is where these takebacks and these drives that the insurance companies put in place to take back money come from, is PCRs and such are on that radar.
So I posted a question in the Thriving Urology Practice Facebook group recently and I was wondering when the takebacks from PCRs are occurring. And some people have already mentioned that they've already been audited and the takebacks have already occurred for some of the members.
Correct. We are starting to see takebacks. We are starting to see reviews, polls for claims. And I know that the painter Mark is also working with several groups who are in big appeals, who have initially been denied, and they're going back in for a second attempt to overturn that, but they are working diligently for that. And then you're still seeing people are not getting the MolDX. We're now seeing that the several payers, WellMed is not paying the PCRs at all now. Humana is now cutting back on even the codes they were paying. So we are seeing that significantly too.
Yeah, I think the heyday for PCR is over. The easy PCR billing those days are over. You now have to jump through a lot of hoops to get the special codes.
Yep.
Yeah.
And you're going to see, along with and again, due to these scenarios, and just some of them that we'll go over today, just these kind of practices do initiate why somebody at the other end gets a job at Humana and says, wow, we could really go back and look at these things and probably recoup money. They get a percentage of it, in some of these, rack audits, stuff like that, and they get percentages and they go after these high dollar items that they can take back, knowing also when we see takebacks on our end, we are appealing them. If we know that they shouldn't be taken back, we're appealing them, even if they take months to do, because it is not right that they're doing that because if we see that it is something that the doctors did, we're back and appealing those. And some people don't do that either.
So one of the, we can go so many,
I know, we can go in
so many different directions with this. Okay, so I'm going to talk about something that is about to happen on May 25th of this year by Cigna. Let's talk about poor billing by certain practices and leading to certain payers behaving in some certain egregious fashion. Cigna, once again, this happened last year. They tried to do this last year, but they delayed it or canceled it. Last year, it's this exact same scenario where any established patient E&M visit code that is billed with a modifier 25 will now, starting May 25th of this year, require that the practices submit documentation of that visit to a separate 800 number.
Correct.
Every single claim with a modifier 25 on an established patient for Cigna will now, starting on May 25th, require this additional documentation requirement. In just in my practice alone, there are a ton of modifier 25 visits every week. So imagine Cigna with, I don't know how many million lives that they millions of tens of millions of lives that they cover, and how many physicians, APPs that they contract with. Now every modifier 25, you now have to submit additional paperwork. Some of it is because of the poor documentation practices that have been done, the erroneous, the wrong billing that is being done by practices. And unfortunately, if you don't do it right, then you're giving insurance companies ammunition to go after you. On the other hand, in your situation, PRS doing the billing and coding on behalf of urology practices, you know you're doing it correctly. And if they are
Correct.
trying to deny your claim, then you're saying that you appeal every single one of them.
Every claim.
Now, one of the advantages when you do appeal, and you should, when you do appeal, and these insurance companies, on the other hand, they will look at these claims from these entities or these practices that are appealing correctly, and now they are paying you on appeal.
Correct.
It takes work for them. It takes more effort, energy, and workforce to work these appeals because they are under contract to adjudicate these claims.
Correct.
If they notice that a practice is doing things correctly, consistently, what have you seen from payers?
Not from Cigna, but from other payers, we have noticed a decrease or actually stopping the requests for the medical records. This one's all across the board with Cigna, but we have several payers, Blue Cross, Blue Shield, Humana being a couple of them, that are requesting notes on every single 25 modifier, and that has decreased as we've been pushing them through, sending the documentation, our follow-up, our notes, and this is decreasing significantly. We had a staff member who was working Blue Cross, and that is the only payer that he was working. He spent probably more than 70% of his day with medical records, sending on 25 modifier requests. We have now decreased that. He's maybe spending 5 hours a week sending in those records for the requests. Now, for actual big procedures, a little bit different, but with the 25 modifiers, when you're fighting those things and they are not they're not denying them again, they're cutting back on that because, like you said, they also are short-staffed, and we do know this. I'm interested to see with the Cigna letter that came out to everybody, if at some point they will maybe send a letter to certain providers stating they're not going to request that from them anymore. I think that they are going to see that providers are not going to follow up and send the records, so they are going to see a savings. I worry that that will be something that other payers follow because they're going to post that they're saving money. But I also know that the work, exactly what you were just stating, is significant. When we send appeals out and we are printing that data, we're writing letters, we're calling, we're staying on the phone, we're tying up their staff, somehow that's going to affect them negatively in their, financial status, because it takes a lot of time when we're on the phone with them, sometimes 45 plus minutes, dealing with an appeal and making sure that we're not getting off the phone until they tell us if they're going to process this or where the status of the appeal is.
Well, that just kind of goes to the ridiculousness of the entire U.S. healthcare system. But I'm not going to go.
Yes.
I'm not going to go there. But there are certain entities, like you said, RACs, recovery audit contractors, that will. These folks are incentivized by catching mistakes by payers. So the more money they recoup from the providers, the more money they are paid. So they are incentivized to recoup money, sometimes right, sometimes wrong. The more they recoup, the more money they make. So the incentives are kind of, well, I mean, I guess in Medicare's case, they want to incentivize these third-party contractors to recoup as much as possible. But there are entities out there that do nothing but to try to claw back payment after they made the payment to you. It pays to understand the rules. It pays to apply these rules correctly, and it pays to do things right the first time, because that is the cheapest way to submit the claim so that you can get paid in the most timely fashion. Do things right the first time. And that, of course, requires understanding and also how to apply these rules, these coding rules.
Correct. And when you're dealing with this situation in particular, and as we'll see more, I'm sure, plan for this. Since they sent the letter out, make sure that you have somebody in your office who can take this volume. If you're higher volume Cigna, make sure that you are able to send these in a timely fashion and able to follow up that the medical records were received. As many people with United Healthcare, when they started using Optum as well, in the background, they started using Optum, and those, it was a separate number, separate address, and we were having to call on these claims and sometimes sit on hold for 2-3 hours. This will be the same situation. We're going to see them say they did not get the claims and they did not get the records. We're going to see them let us know that the things need to be resubmitted. So please make sure that you guys have this process in place when you're dealing with this.
Something else. So there are basically, I looked at the Cigna letter. There are basically 3 ways to submit these claims, this additional documentation. One will be through the 800 number, which is, I think most people are going to do that. 2 is through email. And you want to make sure your practice is set up with secure email, encrypted email, so that you can send these. I think maybe that may be the fastest and the most efficient way to send these in, because you now have an electronic trail to say, hey, guess what? We sent this in and here's the receipt from the encrypted email. And the third option, of course, is snail mail. Nobody's going to do that. Nobody
wants to do that. Yeah. Nobody wants to do that. And if I would recommend, if you are emailing, and I do agree that is the fastest, you state who sent the encrypted email, when it was sent, so you can easily go back and find that trail when you need to fight that claim. Because also Cigna has a timely filing. So, and a timely filing for following up. So if you don't have this in process, you could not send the records, wait 3 months to follow up on the claim, and then be out the money anyway, because you're sitting there and you're seeing that the claims aren't being paid and you're following up on the claims. So just make sure the process is there. And if you have a lower volume of Cigna, still make sure you're following up with the claims in a timely fashion, but make sure that can be maybe a once a week process where somebody can send those records in.
So just to jump back to what you said regarding your person who does exclusive Blue Cross pay, you're saying that initially he was spending a lot of time sending in appeals, but now he spends maybe only 5 hours a week to deal with with documentation requests, because you set the tone. You have shown them that these entities, these practices whom you represent, know what they're doing.
Correct.
And that's why they decrease the documentation request.
Correct. And we make it to the dumbify it down. For example, when you don't know who on the other end is seeing your appeal, they could just be looking at it and saying, this doesn't qualify. We highlight the items. When 25 modifier, we're highlighting the visit, where the doctor's saying this is separate and identifiable, and we are actually putting that in and adding a letter on the front that we just fill in data, and we are sending that in as well, so that somebody can easily read that and go, okay, I see these points. Make sure it's easy for them, and make sure that they're wanting to just push your claim through. If they have to read through all those documents, they may still misinterpret your use of the 25 modifier. But when you're highlighting it, when you're also putting a cover letter that states this provider clearly documented X, Y, and Z, you're going to see them process your claim probably 90% of the time.
I love what the word that you used, dumbify it.
Yeah.
Dumbify it. You want to make it easy. So this is a very human phenomenon. I just love human behavior. Anything you do to make it easy for the person on the other end to take the action that you want them to take, anything you can do to decrease that friction, they are more likely to take the action that you want them to do. And what you're saying is that here's the documentation, here is the separate, significant and separately identifiable service, and also the documentation for that service. You circle it, you put arrows, and you say, and you maybe put like A. Please see A. That is then, where significant and separately identifiable documentation took place according to CPT,
Correct.
This definition of modifier 25, you're almost like it's almost like you're arguing a legal case. You're showing evidence that you have been compliant, and then there's no cause for you to reject our claim or deny our claim. But
correct, and it's a repeatable process. So if you create these templates, it's a repeatable process for your billing team, your RCM team, to just fill in the data. They that now are supplying that. We often say we're detectives and we're supplying all of the evidence for the detective work that we're doing. So we are sending that to the payer. So it's very easy. Exactly what you said. A, look here. B, look here. C, look here. Here's CCI edits. Here's your ruling straight from your payer website. And usually we see the claim turn around and pay.
But the thing is, the reality is that not everyone will be doing that. And that is where the insurance companies are going to win, if you will, because they know maybe 5% of the claims are appealed, according to the ProPublica article that just came out regarding Cigna auto denying hundreds of claims a month.
There's a reason they're doing this.
1.2 seconds per claim denial.
Correct. And I think that some of it comes from misunderstanding about billing and that claims don't just fly through the system and bill. But also I think that the people who are working the claims often don't understand what they're supposed to do to get that claim reprocessed. They're not understanding the denial that's being set forth in front of them. So they go to the easy, low hanging fruit, as you call it. And we're going for this ID number wasn't correct. So they can correct the ID number and send that through. And those claims sit there and then they face and risk timely filing. So I think that twofold, you can educate your team to understand what the denials are and what you need to do to overturn those denials, whether it be appeal or corrected claims, but also just understanding the RCM process is not a turn and burn. You don't just send claims through and the insurance companies pay them. They do not do that. They clean claim rate, great, but even clean claim rates can result in denied claims that need to be appealed.
Yeah, the billing process is dynamic. It's not just, sometimes the straightforward claims, you can just send it through and it comes right back. But what you said is really telling. A lot of folks who work appeals will just work the easy appeals.
Correct.
Like you said, ID wrong or some demographic that's wrong. They work those claims. But then some of the more difficult ones where you have to spend a little bit more time doing research, writing letter, often they fail at those because it takes more work. It takes more brain power to actually create those letters, making those links. But to your point, once you do it, you can reuse it the next time.
Correct.
And sometimes not just one payer, but you can use the same template for multiple payers.
Correct. And it lets the process be a little bit easier if you are promoting a person who's in the RCM department and you're refilling that position, somebody leaves, and it allows that new person that's coming in to have a template to use that's been working for you. We use it a lot with UroLift. When we have a couple providers who use over the MUE units for UroLift and we send in the form, this allows the person on the other end to very quickly go through, check. These things are done. This person already did the work for me, showed me where it was, and it is a lot faster process. We see a lot of times where offices are not doing the front desk items. And that's one of the stories that we've seen actually quite frequently in the nightmare stories is the processes at the front desk that are not being completed. And we often hear from providers that they don't have time and they don't have money to put more people in that process. Where we've gone in often and quickly seen is the lack of eligibility check and lack of completing and updating data, insurance cards, and collection of copays, which has resulted in hundreds of thousands of dollars of write-offs. When you are seeing a patient and you do not get the correct data and then there is no follow-up on your claims, you're then subject to a complete loss of that revenue. You are not able to get a hold of the patient anymore. They're not calling you, you're turning it over to a collection agency. Your insurance companies have denied the claim. Nobody's following up and to turn to the patient. So we've also seen scenarios where we've gone in and we're writing off $1.8 million worth of AR that was not correctly collected at the beginning because eligibility and benefits were not checked prior to any patients being seen.
That just makes me sick.
Yeah, and it's happening just as recent.
Yeah,
it is a big thing that we see in the RCM portion, and I know that people who are listening, they experience it, on a smaller level, most likely, because again, we're all sitting here trying to better ourselves. Providers who are trying to do this at lower cost are really suffering and making it worse for themselves because it is crucial to get the right insurance. I have changed insurances in the last year. If I went to the doctor, they didn't ask for my card, they're going to bill my old insurance. And that happens frequently. So those are the stories where I really struggle with because it was such an easy process. It's even prior to electronic medical records, I worked at a front desk. You collected the insurance, you collected their demographics, you made them sign an updated form each year. That is a process that has been needed from the beginning. And if you do not collect the right data, you do not collect your copays, you do not collect your past due balances, you are at a loss. And we see this so much.
Wow, 1.8 million is a lot of money. So I'm going to turn to the listening and watching audience real quick and remind them that if you have any questions, comments, suggestions, please leave them in the comment section, either during the live stream or afterwards. If you're watching this on the replay, please feel free to leave the comments. Marianne and I would do our best to answer all of them. And like you said, Marianne, getting that information correctly at the outset is important. But you also said something about the front desk work that is not being done. And I think you were referring to maybe some of the Urolift procedures.
Correct. So when your front desk work, also pre-service work, as we've discussed in previous shows as well, is essential to making sure that you're getting paid. Urolift procedures, they require authorization, predetermination, whichever one you're doing, or if you're doing both. And they require not only to make sure that the procedure code is payable by the payer, but the diagnosis code and what you're using. Also, as we know, Urolift has an MUE maximum unit that can be billed. So if you're going to be billing over those units, you're going to be appealing with notes. Make sure in those notes, if you're a provider, that you're stating why you're going above and beyond the units, so that it is easier when we send the appeal that the account can get cleared and paid quickly, because that's a item that you guys are paying for and you want to have fast turnaround. And if you are billing above the units that are accepted by Medicare and other payers, you're going to have to send that to appeal, and you want to make sure you have the documentation. The front desk is responsible, or your pre-service check, whoever's doing your authorizations or your surgery schedules, whoever's doing that in your office, need to make sure that those policies are set in place, because authorizations now are very time-consuming and needed resource in your office. If you do not have somebody that's doing this for you, you need to have somebody doing this for you. I can assure you, if you're not having somebody do this for you, you're having a loss at the backside of your RCM once the claims process.
100% agree with you. In a podcast that I did with the painters Mark, Scott, and Ray, I think it was last year, I almost lost over $8,000 in an MUE, medically unlikely edit Urolift case. And that I went all the way up to the administrative law judge to show her that everything is there. This is the reason why I did the MUE, went above 7 units. Here's the documentation. And the payer tried to catch me on a signature. There's no signature. Well, the documentation, the entire thing, the encounter note contains an electronic signature, but the procedure note was separately documented. So they just looked at the procedure note without looking at the entire encounter note. The signature is there, but they just saw the procedure note. Whoever's making the appeal needs to clearly show whatever the objection is by the MAC or the payer.
Correct.
You have to show them why their objection is wrong through
Correct.
evidentiary presentation in a document, in a letter. And I think that is what is so difficult for a lot of coders and billers. Not only do you have to understand the rules, the CPT rules, not only do you have
Correct.
to understand the payer requirements, and now you have to create a letter
Correct.
to fight this denial. I think that is what is so difficult, because I hate to say this, just like not all urologists are the most amicable people with the best personalities. They may have great technical skills, but they may not be the most personable, right? You
Correct.
have coders who are very technically competent, but in terms of reading and ingesting the denial letter and then coming up with something to counter it, they may not have the skill set to do so. And that is another source of revenue leak for physicians.
Correct. And in our process at PRS, I feel like the knowledge is power. Obviously, we've talked about this before. If you have, as a coder, if you are having somebody code data all day, every day, and they are not understanding the entire process that happens from the start of the claim to the end of the claim, you're also getting them into a box where they aren't thinking outside of that box, and they're actually not able to give data back or suggestions back to not only the other RCM staff, but the providers. I feel that, and we've talked about this before too, I feel like that is missing because a lot of times the doctors do not know that there's a maximum unit that needs to be used with a UroLift. They're not understanding that. So they're just, oh, I want to put in 8 bands. Okay. And they're not understanding their documentation needs to say something different. And that feedback loop allows for payers to stop doing this to your practice. If you are communicating from start to finish, each person, we often have our coders start in charge check, which is a data entry process of adding the modifiers, making sure the diagnosis codes are there, because it's a process that allows them to understand what needs to happen and what happened from the start of the claim that possibly unraveled when they are now reviewing the coding and the denials that are coming back through to them. I truly believe that more education to them on the entire process, even the provider's process. I feel like some of the best practices that I've been into, the doctors are also letting the staff know how these procedures are done. I know for myself, I sat in an entire day watching urodynamics when I was early here at PRS, and I understood from watching these procedures happen all day long what the urodynamic process entailed. And then I started understanding bundling, why the catheters bundled into the procedures, because I now understood the process. We encourage people here to watch YouTube, watch the YouTube videos on cystos, watch the prostate biopsies, watch these items so that you can understand what you're billing for, and it helps you to peel better. When you're writing a document, you're going to know how that process worked to be able to better state to the insurance company, no, this is clearly in these notes. Because I do think technically you can look at things in black and white and be able to say, okay, here's this, this, this. But when you also know how it was happening and how your doctor works, you're going to be able to better tell the story to the payer and get these things paid.
Excellent. Now I'm going to read some comments. Monique says regarding the Cigna modifier 25, regarding the documentation requirements, she says it's going to be a nightmare. And she also said relative to the UroLift payer requirements, that UroLift website has specific payer-specific requirements on the notes that are needed. For instance,
Correct.
Lack of urinary incontinence,
Correct.
lack of gross hematuria, lack of urinary tract infection. If you know going in to counsel the patient, and if you, the physician, the
Correct.
urologist, if you know what is required in terms of documentation, you can pay a little bit more attention and maybe copy and paste what is
Correct.
required, the required verbiage, because you know it's a fact, but you just now need to write it down. And once
Correct.
it's there, it makes it a lot easier for the folks who are coding and billing for it to, if they need to submit the claim and if they need to submit documentation, it's much easier for them and for you, the doctor, to be paid and reimbursed, because each one of these implants is $700-800. So
Correct.
$700-800 that you're sitting on not being paid. And worse yet, if there's an MUE audit, because anytime you go above MUE, medically unlikely edit, it's going to hold up the claim. And you,
Correct.
I hope you have all the ducks in a row and that the documentation is there so that you are going to be paid for all of these implants that you just placed, because one mistake on one implant can blow all the potential gains that you could get from performing this one procedure.
Correct. And when you know that that's a possibility, if you have a provider who's usually going over the number of units that are allowable, then you are able to set the process and make it very easy for yourself in the RCM portion of it to appeal, which is what Monique, I believe, does. And what we end up doing is, this is now an easy process. We've told this provider what we need in the documentation. He doesn't have to worry about it. We know we're going to appeal. We know what documentation we're sending through, and this allows it to be a very repeatable process and very easy for us to identify the items in there. We see this often. Again, we've gone into practices who are not doing this. They feel like, okay, I'll just change the units down to what they will pay for. And we've seen this over and over again, instead of making the work to understand and educate yourself on what actually needs to be done so you get paid for the units that you paid for initially.
Yeah, I agree. And Rock Sour, I think that's Raquel. She says,
yes.
She says, preach, Marianne. And Monique said that I have the process down now, which is amazing.
Yes. And she's been able to, these are both two of my staff members, and they both have been able to excel. I mean, excel, both of them coming into the medical billing world with little to no knowledge. And they've been able to excel in a state where their suggestions come back to the clinics. These clinics are listening to them, stating, you know, they can come back and say, hey, we need this. They can talk directly with the providers. And this is the closing of the loop that is fascinating to see when you see a troubled client that comes to you and they are in massive trouble. They have claims that have been sitting there for a year. People have been just cherry picking what's going on, and you are able to clean this practice up and not only just get claims paid, but clean up processes. Usually it comes down to cleaning up the AR is not just what you're doing. You're cleaning up processes so that this can be a streamlined assembly line process, and the providers can do their job and they can count on you to do your part of the job. And when something's going wrong, you converse, you talk, and you fix a problem. You add a note in the documentation now, and they don't have to worry about it again, and they know you're going to come back to them. And I think that's key in every sense of the way. If they understand that they can trust you, that you're going to come back to them if there's a problem, then they can focus on their job and you can focus on getting the claims paid.
So a couple of things. Number one, communication. You have to talk to your billing staff. Speaking from a urologist physician perspective, you have to talk to your coding and billing staff. The conversation is two-way. Just today, my biller, Krista, she sent me something about something that Aetna is doing with our UroCuff procedures. And I know, using the AUAcodingtoday.com's bundling matrix, I know the codes that they're trying to screw us with.
Yes.
They're both payable and you can bill both, but they're trying to deny one of the codes. They're not playing by the CPT rules, the bundling rules.
Exactly.
So now they're saying that you should consider a 7 series code. I'm thinking, no, I don't think so. They just need to follow the CPT guidelines. But that's the type of communication that is required. So that the problem is, urologists we're just too busy. And I think maybe some of this is by design by the powers to be, the higher ups, is to keep the urologists working so busily in the practice that they don't have time to lift their heads up above water, take a breath, so that they could work on their practice.
Correct.
And I think that's part of the problem. That's why a lot of urologists, hopefully, thankfully, not a lot of them in the Thriving Urology Practice Facebook group, because we have some really, really astute coders and billers. And I hope that some of it is due to our doing in educating everyone here. But unfortunately, not everyone is well educated in the realm of coding, billing, revenue cycle management. And I think I feel badly for those practices, because I know what the potentials are in how the practice can perform.
Correct. And I don't think that they understand. I believe that they've got this set goal, which I actually do know from talking to many, many urologists, many practice managers. They have a set goal. I need to make X amount of dollars every month to meet my bills and payroll. So they meet that, and they don't realize, because they're hearing from their, billings, insurance companies aren't paying. This is so difficult. This is going here. And they get used to that set amount, not realizing what they're leaving on the table and what they're allowing the insurance companies to get away with. When you sit down with them and you point out these factors, you point out, by the way, hey, you are only authorizing a 55700 with your prostate biopsy. There are several other codes, including gentamicin, you need to put on your auth, or these don't get paid. You would be surprised on how many people go, what? You mean I only got paid on the 55700 and I didn't get paid on the 7697? You didn't get paid on any of it. All of those were not on your auth, not the administration codes, none of it. We had clinics that were only doing the E&M on their authorizations on a high level referral process when we first started with them, only doing the E&M, nothing with the UAs, not putting the cystos on their authorization, only the E&Ms that were getting paid, and the other items were getting written off to no auth. Come in there, start correcting their authorization process, and you take them from averaging, $90K a month up to now averaging $260,000 a month, and just from simple items such as that process, for which the provider did not even understand. You guys are not in business to sit here and do authorizations. You're seeing patients. This is for somebody to come back and relay to you, but nobody had relayed that back to the providers, stating that these things were being written off for no auth and we could fix it. Instead, it was being relayed as you didn't get an auth and there was, no solution was presented. So we have to write them off because we can't bill the patients. And in that case, that is a huge revenue turnaround to a highly successful practice now. And when we are in there and dealing with this, if these are just process changes that we're coming in and saying, if you do it this way, you will see change. Then we can now work on the denials that come in through the back that are actually items that we need to appeal, instead of writing off auth items or trying to ask for retro auths, which they're not going to give you.
No. And so you were saying that doing things right from the front end, on the front end, is going to help a lot. For instance, what you said, pre-authorization, getting the authorization, getting the predetermination for something as simple as a prostate biopsy.
Correct.
Making sure that you're not just getting prior auth for one code. Make sure you get it for the ultrasound needle guidance. Make sure you get the code if you provide it. The administration and also the medication,
Correct.
the gentamicin, if you do that. Making sure that you get the prior auths and predetermination for all 4 codes, so
Correct.
that you can be properly paid. And like you said,
Correct.
90 to 200 to 260K, that is no chump change. And just imagine how much happier you can stride into work. And
yes,
I'm
exactly.
going to encourage all the physicians out there that once you achieve that level of success, that you make sure you take care of the staff who helped get you there. All right. Make sure you pay forward. Make sure you pay it backwards. Make sure you say thanks to everyone who helped get you there, because this is truly a team sport.
It truly is. And these nightmare stories that you see, nightmare meaning these practices who we hear, we all hear it all the time, barely getting by. Things are getting more expensive. These are things that you can do that are very easy to put into place. And yes, it will take a little bit of time to get everybody on board and running like a fine oiled machine, but these are little things that you can do to fight back to these payers who are doing these things for their own gain. They are self-denying, denying through computer claims. You need to follow up on these items. And if you're a provider and you're listening, if you aren't talking to your RCM staff, I highly doubt that anybody on this call probably isn't. But if you aren't, go and have a conversation. Ask them what's going on. Ask for a report. Start looking at, and have that conversation open with them. When you start making that comfortable between the two of you or your teams, it ends up becoming very easy for them to come talk to you as well. Sometimes I know that I also hear going into practices, oh, I can't talk to my provider. They're really busy. They don't have the time. And once you open up that conversation, that person on the other end, I think we look at you guys as providers as, a higher level. You guys are our bosses. You guys are very busy. You're doing surgeries. That's to some people, that's very, intimidating. And so when you open up that conversation with them, you will be surprised also. And I've said this before, your team will thrive on that because they want to now show you things that they've done right and things that have been going wrong that they now need your help to fix. And
I'm going to discuss something that this is something that the airline industry does, and it's a concept called just culture. Just culture.
Yes.
Is that you don't just blame people for screwing up. You learn, you go to the root cause to make sure this doesn't happen again in the future. You don't blame the person, but you find the root cause so it never happens again. This just culture needs to translate to every single urology/medical practice. Correct. You want to make sure you're optimally working. The situation you're suggesting is that this is not even money that insurance companies trying to screw you over for, but this is money that you are screwing yourself over because you're not getting the predetermination, you're not getting the prior authorization, and it is your contract to which you agreed when you signed up with the insurance company. So you are literally screwing yourself by not implementing these processes.
Correct. And if you are a provider who's stating, I don't have the money to put somebody else in this place to do this process, I would say take a look, stand back, take a step backwards and say, how can I afford not to do this? The ROI on this will be great. It is an item that is needed, and it will continue to be needed in a greater capacity in the coming months and years. This is not going away. The insurance companies are going back to the days when I first started, and every single thing needed a referral. And in order to go, I first worked in primary care in order to see. And if you do not have that, you are not going to get paid. They're slowly going back to these processes because practices are not doing these steps, and they are winning on the other side. And the insurance companies don't have to pay your claims because you didn't get an auth, you didn't have the right insurance to begin with. So it took you, 7 months to bill United Healthcare, and now it's out of timely. These things are items that you can prevent and allow your staff in the RCM department to actually look at claims that need critical thinking. It is unbelievable how many practices I have been into where the majority of the aging AR work and claim status work is being done is correcting demographic errors time and time and time again. And this is low hanging fruit for them because this is easy for them to fix. And therefore your large procedures, your nephrectomies, your 22 modifier claims are not getting paid because somebody does not have time to go and appeal those items because they're facing that 80% of your claims didn't get put in the system correctly, and they're just having to fix those to get to the right insurance.
So let's talk tactics.
Yeah.
How do you minimize the wrong information, the wrong demographic information being entered into the PM system?
I would suggest that you look at your PM system if you haven't already and make required fields. Most practice management systems will allow you to have required fields to be completed by your front desk staff. Setting up policies to review, we've talked about this, once a year is okay. Sometimes people are changing insurance companies in the middle of a year. So we recommend 6 months. Each 6 months, have somebody re-review what's been in the system. If they just say, I got the same insurance, ask them on the sign-in sheet, if you're not already doing it, to write down what insurance they have. If they don't write anything down, they just signed in their name, have some way to ask them. Kiosks in your practices are a way also that they have to actually go through and check through the processes, and they have to enter in some data. That is a way to find out that somebody has different insurance. And in the case of your staff, policies, starting off with I'll use the word manual process, so they understand the checks and balances that have to happen at the front desk, is a way to go back to the basics and allow them to know what steps they have to take on every single patient that goes through there. The last part of that is making sure you are consistent throughout your practice. Several of the nightmare stories that I also face is practices with multiple providers, whether it's more than one, where the doctors practice differently. You are a practice and you practice differently. So you are already letting your front desk staff fail you because they can't keep up with Dr. Jones and Dr. Smith, because each of them does items differently. They do collections differently. Some will see patients regardless of past due balances, others won't. And when you have practices that have 5+ providers, this becomes very impossible for the management team to manage the front desk and the front desk to do the right thing. So if you're practicing if you're a practice as a practice, so you can have set workflows, set processes that allows very easy monitoring. If you are able to do that, then your management team or your leads are able to monitor on a weekly basis and come back to your staff and say when things are going wrong. If you have 5 different processes, it is very easy to just be like, nobody's going to notice. And I don't have a real good monitoring process. But making sure everybody in that office knows what is required on every single patient, making sure that gender specific data within your practice management system. We talked about this, your ICD-10 codes, they're gender specific. Make sure if your practice management system allows you to make sure that the gender is correct before you check that diagnosis, use your practice management system to the best of its ability and set checks and balances in there as well.
And also in your electronic health records, sometimes if the gender is not correct, it will not allow me to pick a BPH with obstruction for a female gender that is entered in the PM and demographics and then gets sent over to EHR. I can't even, that is not even part of my pick list on my short list on the EHR side. So I can't even make that mistake. So make sure you utilize the automation and the simple logic that is already present in your PM system and in your electronic health record system.
Correct. And, I know that billing, coding, it's exciting to me. I get very excited when I'm able to solve a problem. I love solving problems. I love being faced with a challenge and coming up with a solution that works for a practice, for my staff. If you are able to go back and you're able to look at items a little bit differently, one of the things I take back from the PRS coding seminars each time I go there is the coders and the physicians love to go through scenarios. They love to go through the scenarios. You guys as managers and overseeing teams or in the RCM, same kind of thing. Develop a scenario for them and do a training session that says, what would you guys have done differently? Here's a claim. It got denied. What went wrong? The same kind of things, because then they start thinking, wheels start turning, and the people who don't know, who maybe be afraid to ask questions, are then educated from those scenarios, and they might now go dig into other items and bring up something and fix claims in the future. I see that if you're able to, instead of going and saying, hey, you didn't do this right, you need to do this right, start using those scenarios as education, because most of the time it's not just one person who doesn't understand that a 78 modifier should not go on an E&M. It is more than one person that's doing that. So make it a little bit so you can have an education workshop, whether that be monthly or every quarter. Use those scenarios that you're finding in the backside of your RCM to come back not only to your providers and your admin team, but your staff. Make it fun for them, because this is interesting to most of us. We are all wanting to, most people, I shouldn't say everybody, but most people are wanting to achieve to the greatest potential. They want to please me and my, as their supervisor, you guys as providers. They want that. And if you're able to give them those scenarios, they are feeling more secure and more more able to deal with their positions that they're in on a daily basis and come ask you questions.
Yeah.
I know that that's what we do when we're going into these practices. It is a lot of times that people don't want to ask questions, and therefore they just do something and they don't really tell people why they're doing it. They just are like, oh, this person was argumentative at the front desk, so I didn't ask him any more data, so I just got his first name. If you make that requirement in the practice management system, then they have to ask him.
Right. Otherwise, the patient cannot be seen on the back end.
Correct.
Yeah, so important. And when it comes to, I'm going to say a couple of things. Number one, if you're wondering what Marianne is talking about when it comes to the PRS Network coding course, it's called the Urology Advanced Coding and Reimbursement Seminar. It happens twice a year, and for the fiscal year 2024. The first meeting will be in December, and typically it's in Vegas.
Yes.
And then the next meeting will be in January. It could be in Florida or it could be in New Orleans. So stay tuned. You can look at prsnetwork.com for updated information once we get closer to that time. And the reason it's held in December and January is because CMS, Medicare, the largest payer in the U.S., puts out their final rules somewhere towards the end of November. And once we have the final rules, everyone rushes to package all that together at the December seminar and also the January seminar. So you have the latest and the best information going into the next fiscal year. Second topic I want to discuss is that you said, Marianne, if you have 5 providers and they all deal with finances differently at the front desk. For instance, I could be one who says, "Oh, come on in. I don't care if you owe $400 from a prior balance that you never paid. I will still see you." But the next physician says, "Oh no, you need to satisfy your financial obligations per your obligation contractual agreement with your insurance company. And per my contractual agreement with the insurance company, you need to satisfy that first before I see you for an elective problem that we're dealing with." When you have that conflict, it's impossible for the front desk. We're just talking about 2 different physicians. Imagine it, like you said, Marianne, if you have 5 physicians, each operating differently, it's a recipe for absolute disaster, because the front desk either, like you said, can get away with whatever they want to do because they can say, "Well, I thought so-and-so wants it done one way," and the other person wants it done the other way. You want to have a consistent policy at the front desk when it comes to collections. Not only that, you want to empower the folks at the front desk to be able to make executive decisions. And it is the duty and obligation of the physicians to back them up on those decisions.
Correct. And the biggest changes we've been able to make in those situations is just that. Have a uniform policy for which your front desk knows, I have these steps to follow, and at this point I escalate. That way they can state, "I'm sorry, sir, our office policy is this. Do you want to pay? How would you like to do that? Or I can reschedule your appointment." Obviously, there's exceptions, and you will be able to lay those out with your staff, emergencies, appointments, items like that. But making those a small exception and actually making those to the escalation part where the office manager makes those decisions. What we see often is that exactly that. 5 providers in the one case that I'm thinking of, and each one of those does things entirely different. It allows for somebody at the front desk to not only be maybe lazy or just lacking in having to do follow-up, but also sometimes nervous and scared because they don't remember which doctor does what. And the training of that on the backside is nightmarish. When you're talking about training of a staff, we all know in staff turnover, it's an investment. You're investing in this person. And if you're not able to supply them with tools that allows them to succeed at their job, then most of the time they're just going to get by each day until somebody notices and possibly now is writing them up to no fault, maybe a little bit of fault of their own, but sometimes no fault of their own because they just didn't have anything to actually go by in guidelines.
Yeah, poor
we see
training.
This often.
Yeah, poor training. And also to circle back to the first scenario that you discussed, having that person just applying the lump sum payment to a particular payer without assigning the payment, the remittance to every single individual patient's account. I mean, that's the kind of nightmare that you don't ever want to deal with.
Well, and I think that I'm, again, we're talking with people who are on this call and are going to listen later that are trying to educate. There are several people who are not in that same scenario or do not even have nowhere to go for the resources of this. We see with modifier usage, there's a definition of a modifier, and that modifier gets items paid. This is one of my nightmare scenarios, is that throwing modifiers on items, throwing diagnosis codes on items that are possibly from other visits, are items that the doctors they may not know is occurring. And the staff that is doing this does not understand the ramifications and the liability on the providers in the practice for doing such thing. Getting a claim paid does not mean it was the right thing to do. Understanding modifiers is one of the items I feel that many people misunderstand. Not only why they're being used, when they should be used. It is common that I'm on calls that say, I got the claim paid. Well, the claim paid. Okay, well, it wasn't right. This your actual documentation did not support this. This is what we need to do moving forward. So those are the scenarios where we've come into practices or talked to practices where they have received very significant takebacks because of that process of, I just need to get claim paid. If you know that PTNS needs a certain diagnosis, that doesn't mean you as a biller should be applying that diagnosis if it's not applicable to that claim.
Yeah.
It is, you have to make sure this is one of the scenarios I have seen over and over again. You pick up a note, you know that this is on the LCD, you just apply the diagnosis and it's not any part of the note. Even if it's one digit off, it needs to be that diagnosis on the LCD and that diagnosis needs to be in the note.
Yep.
So those are the things that we see common as well, is just a common misunderstanding of, I'm not just sending this claim to get paid. I also need to do the right thing and making sure that it is a part of that note.
It is unfortunate that this system is so complicated because you have the local coverage determination, which dictates what ICD-10s or diagnosis codes are applicable to this particular procedure. And then you have the actual encounter note by the physician.
Correct.
And sometimes it doesn't quite satisfy the documentation requirements for a particular ICD-10 that is required by the LCD.
Correct.
So you can't just pick the diagnosis code from the LCD and just stick it on your claim and just push
Correct.
it through just because that's what's required. The encounter note has to support the diagnosis code that is actually being used. So
Correct.
Just because you were paid doesn't mean that you coded it correctly. So that is something
Correct.
that is a recurrent theme and pervasive problem. Hey, Marianne, we have gone over a little bit.
Yeah.
You and I can talk forever about this. And what do you think? What is the next topic that you're passionate about that you want to discuss the next time we get together?
I was thinking when I was over the last couple of weeks of thinking, is there something that the audience is really needing some information on? I know that the appeals process is an item that we get questions on as far as a documented workflow, repeatable, as I commonly refer to. how we store that data, what may be required in an appeal, and how to better make that process in your office. That is one of the things that I think is important. And also what we're seeing right now in the authorization process with the amount of documentation that's going through prior to a physician actually doing the procedure, and the changes during a procedure that are not being relayed back and causing claims to not be paid, are two things we're seeing an increase in as well. So I guess on my end, I can talk about billing forever. It's really fascinating to me.
Yeah.
Very, very interesting. I work with Mark, so I do a lot of stuff. Anything that someone wants to shoot out to for a recommendation on another topic, I will think a little bit more, but I do think we need to talk a little bit more about authorizations and what is to come, what we're really seeing. And then that process of maybe, I know that during those seminars that we do with PRS, they ask, what can I do to make this easier for my RCM team in storing these documents? I would like to present. I have a couple of people here who have a very good process, and we store their documents and have templates, maybe discussing how they can create those and fill those in very easily for these common errors that are happening from the payers.
All right. So probably maybe appeals, the nuts and bolts of appeals, or the prior authorization process, and how to do it well.
So, I think that is a very common thing that's actually escalating in our world.
Okay, so for the audience that's watching, or something else, if something that is bothering you, or if you have issues in your practice, specific items that you want to discuss, please leave it in the comments, and maybe Marianne can pick one, and then we will get together again in the near future to discuss this.
Yes, correct. I think that some people have reached out to me and asked me questions. So if there's something that they really are having a struggle with, we could discuss that as well.
All right. Well, very good.
Right.
Thank you again, Marianne. And I know we can go on forever. We will chat again. Thank you so much.
All right. Thank you. Thank you, guys.
All right. For those of you who have stuck with us for so long until the end, please feel free to leave any comments or questions below. If you're watching this on the replays, same thing for you. Please leave any comments or questions. We welcome them. We're doing this just so that we can make sure that everyone succeeds. Like the saying goes, rising tide lifts all ships. And I want you all to succeed. And I know that is the goal of Marianne as well. Thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.